Welcome back to the Deep Dive. We're here again to really get into the weeds of important research and reports, pulling out the key insights for you.
Glad to be here.
Today we're tackling something really fascinating in global health history, and maybe a bit controversial too.
Definitely has layers to it.
Okay, imagine this. You've got limited funds, really limited, and you have to figure out how to save the most lives, improve health the most across the entire globe.
A monumental task.
Exactly. That's basically the challenge the 1993 World Development Report, the WDR, took on. It rolled out this, well, supposedly powerful new way to make those decisions.
New methodology, yeah.
But like any really big idea, it didn't take long for a serious critical review to pop up. And that's what we're going deep on today.
That's right. You know, the WDR's goal was huge. It was aimed at helping governments, particularly in developing countries, really boost the health of their people.
How so?
Well, it talked about creating healthier environments, supporting different kinds of healthcare, not just one model, and crucially, getting governments to spend their health money better. Smarter.
Okay, so improving efficiency.
Pretty much. And the core method was, for its time, quite innovative. It used epidemiology, the study of disease patterns and economic analysis together.
To do what exactly?
To build this framework for setting priorities. The whole point was to find what they called goodbyes.
The goodbyes, like in health.
Yeah, essential health services, both clinical and public health stuff. That gave you the biggest health improvement for the money spent. It was trying to bring, data-driven thinking to the forefront.
Right, so the mission, fundamentally, was noble.
Mm-hmm.
A shortcut, maybe, to smarter health spending using hard data. Sounds super logical, doesn't it?
On the surface, absolutely.
But, as you hinted, anytime you try to make a one-size-fits-all global framework like that, questions come up, big ones. So where did the critics start finding issues?
Well, that's really our mission for this deep dive, isn't it? To look critically at that 1993 WDR methodology, using this review as our guide. We want to appreciate the ambition, this universal data tool idea, but also really understand the limits that showed up when it hit the real world.
Okay, let's get into it then. The WDR didn't just look at deaths. It tried to measure the quality of life too, right? Which led them to this central metric, DALYs.
Exactly. Disability-adjusted life years. DALYs.
Okay, break that down. It sounds complicated.
It is, a bit. But the core idea is to combine years lost because someone died too early premature mortality with the years someone lives, but with a disability.
So it's trying to capture the whole picture. Not just survival, but the actual health experience?
That's the goal. A single number trying to represent the total burden of disease. One DALY equals one lost year of healthy life.
And do they have figures on that?
They did. The report estimated back in 1990 that about 34% of this global burden of disease was in developing countries, a huge number.
Wow. That really highlights the scale of the problem they were trying to tackle.
Yeah, absolutely. It underscored why they felt this new, efficient approach was so necessary.
So they have DALYs.
Yeah.
How did that translate into finding those goodbyes you mentioned?
Well, that's where the cost-effectiveness part comes in. The WDR proposed calculating the cost for every DALY gained by different health interventions.
Okay, I see. So you compare, say, a vaccination program versus treating a specific disease.
Exactly. You could line up different initiatives and see which ones gave you the most healthy life years back for each dollar you spent. Identify the best investments.
The logic seems powerful. Quantify the impact. Quantify the cost, make informed choices, aim for objective, data-driven global health policy. A really big ambition.
Huge ambition.
But, okay, the critical review starts looking closely at this foundation, especially the big global burden of disease study it was based on. What were the first sort of cracks they found?
Well, it's interesting. The critique wasn't always about the concept of DALYs itself, but more about the nuts and bolts. The data, especially from that global burden of disease study, which was, the bedrock for all the DALY calculations.
What was wrong with the data?
Several things, according to the review. First, just a lot of uncertainty. The estimates for disease burden for DALYs, they varied depending on the data sources and how they crunched the numbers.
Because the data wasn't always solid.
Right. Especially in developing countries, a lot of it came from maybe limited surveys or just expert guesses, which isn't always super robust for these kinds of precise calculations.
Okay, uncertainty. What else?
The definition itself. The way burden of disease was defined was seen as normative.
Meaning?
Meaning it wasn't purely objective science. It kind of baked in certain values or assumptions about what constitutes burden. Critics questioned if it was really neutral.
Interesting.
Then there was a feeling it was incomplete. Did the WDR method really capture all the health needs? Or the complex ways social factors, culture, environment all play a role?
Like focusing too much on fixing problems rather than preventing them.
Sort of, yeah. Some argued it leaned too heavily on clinical fixes, and maybe not enough on broader things like clean water, sanitation, education stuff that fundamentally shapes health.
Got it.
And lastly, even technical things like how diseases were grouped together. Sometimes lumping diseases could hide specific, important health issues within a population.
So it really wasn't just about the math. It was about what numbers you use, how you define them, where they even come from in the first place.
Precisely.
It makes you wonder, can you really boil down something as messy and complex as global health into one single number? Or do you inevitably lose something vital in that simplification?
That's the fundamental tension, isn't it? How much detail do you sacrifice for the sake of having a number you can compare across countries?
Yeah. And this brings us to maybe the most sensitive part of the whole thing, the human element. The WDR didn't just count years, it weighted them. Age weighting, disability weighting. What did those actually mean, and why did they stir up so much controversy?
All right, this is where the ethics really come to the forefront. Let's take age weighting first.
Okay.
The WDR basically assigned more value to a year of healthy life lived by a young adult, say, someone aged 25 to 34, than a year lived by a baby or an elderly person.
Wait, really? How much difference?
For example, a healthy year at age 25 might count as 1, but that same year at age 0 or over 80 might only count as 0.6.
Why would they do that?
The justification often related to economic productivity. The idea, implicitly or explicitly, was that young adults contribute more economically.
Wow. Okay, I can immediately see the problem there.
Exactly. The ethical objections were huge. It basically implied some lives are worth more than others just based on age.
Yeah, that doesn't sit right.
Critics argued it could skew priorities, maybe overemphasizing diseases affecting working-age men, for instance, and it just didn't reflect how society actually values people at all stages of life, a massive ethical debate.
Understandably.
Well-
Yeah, what about disability weighting?
Yeah.
Similar idea.
Similar in that it assigned different values, yes. Here, different disabilities were given severity weights.
Like blindness versus deafness.
Right. Blindness would get a higher weight, meaning it was considered a more severe disability in terms of its impact on a healthy life year. This weight was then used to convert years lived with that disability into DALYs.
And they critique there.
A few things. Consistency was one where severity and duration measured the same way for all conditions. Probably not. But more fundamentally, who decides these weights? The review pointed out that using panels of experts to assign these values, well, it raises questions about objectivity. Are these universal values, or do they reflect specific cultural perspectives?
Right. What about things like discounting? I think I read something about that.
Yes, that was another point of contention. The WDR used a 3% discount rate for future health benefits.
Meaning a health benefit today is worth more than the same benefit next year.
Exactly. Which is common in economics, but in health, critics argued it could devalue preventive measures whose benefits often lie far in the future. It also potentially disadvantages future generations.
Gosh, talk about a deep dive into ethics, putting numbers on life stages, on disabilities. Even if the goal was rational resource allocation, it clearly hits some very deep, very difficult questions.
Absolutely.
It really makes you think about how we balance these grand universal frameworks with individual human worth and experience. A real tightrope.
It is.
Yeah.
And it forces us to ask whose values are getting embedded in what looks like objective science.
So moving beyond the calculations themselves, how did this framework actually play out in practice? The review also looked at the real world stuff, right?
Yeah.
Costs, effectiveness, implementing policies. What did they find there?
Yeah, the practical side was just as complex. Let's talk costs first.
Okay.
The WDR's cost estimations got a lot of flack. A key criticism was that they often left out important costs.
Like what?
Things like what people paid out of pocket, indirect costs like lost wages when someone's sick, even some general fixed costs of running health systems.
So the cost-effectiveness ratios might have looked better than they really were.
That was the argument. By omitting these costs, the calculated cost per daily gained could seem lower, making those good buys look even more attractive, potentially misleadingly so.
Any other cost issues?
Yes, the data, again, cost estimates were often pretty broad, not based on detailed local data, but actual costs can vary hugely from place to place, right?
Sure, a clinic in a city versus a remote village. very different costs.
Exactly. So comparing interventions across countries based on these broad estimates was tricky. And there were technical issues too, like how to handle overheads or shared costs, and just a lack of clarity on the total budget needed for their suggested essential packages.
Right, so the cost side was messy. What about the effectiveness side? Did the interventions work as well everywhere as assumed?
Well, that was another major critique. The WDR often kind of assumed an intervention would be equally effective no matter where you implemented it.
But that seems unlikely.
Highly unlikely, argued the review. Health systems are different, populations are different, cultural contexts vary. You can't just expect the same result everywhere.
Makes sense.
And they also pointed out that the wider benefits were often ignored.
Wider benefits.
Yeah, the positive knock-on effects, like maybe improving child health also boosts school attendance, or better sanitation prevents multiple diseases, not just the one being targeted. These externalities weren't really factored in.
So you might be underestimating the true value of some interventions.
Potentially, yes. By focusing narrowly on the direct cost per daily.
Okay, so issues with costs, issues with effectiveness assumptions.
Yeah.
How did this translate into policy? Did the WDR priorities actually work on the ground?
That was another area of concern. The priorities that came out of the daily calculations didn't always match up with what people in those countries felt were the biggest needs or what was politically feasible.
Ah, the politics. Always a factor.
Always. Implementing the suggested essential packages often meant shifting budgets around in big ways, which is politically really hard to do. Ministries have their existing priorities, relationships.
You can't just wipe the slate clean.
Not easily. And some critics felt the whole approach was too focused on short-term fixes, these specific interventions, rather than a long-term strategy for building stronger, more resilient health systems overall.
So, pulling this all together, what's the big picture here? It sounds like the WDR tried to create this amazing universal data-driven tool for health policy.
Which was incredibly ambitious and pioneering for its time.
Right. But the real world, local differences, ethical dilemmas, even just counting costs, accurately turned out to be way more complex than the model allowed for. It shows the limits of that purely quantitative top-down approach.
I think that's a fair summary. It really throws into sharp relief that constant tension in global health, doesn't it? We crave these simple, comparable metrics for making big decisions.
And you have to decide somehow.
Exactly. But that clashes with the messy reality of diverse local conditions, different values, complex systems that just don't fit neatly into boxes.
Yeah.
It really pushes us to look beyond just the numbers, to ask why an intervention works or doesn't, how it impacts real people, and to consider that human element that no spreadsheet can fully capture.
Absolutely. So, just to recap for everyone listening, we've walked through how the 1993 World Development Report aimed for this scientific rigor in setting global health priorities, using DALYs and cost effectiveness as its core tools.
A landmark effort, really.
Definitely. But we've also unpacked the critical review that highlighted the challenges, big challenges, from whether the data was reliable enough
to the really deep ethical questions about weighting lives based on age or disability.
And right down to the practical problems of estimating true costs and getting policies implemented effectively in diverse settings.
It's a powerful reminder, I think, that knowledge isn't just about having the data or the framework. It's about understanding it critically. Well, it's not enough to just accept a model like this. We have to constantly probe its assumptions, ask about its limitations, think about what it means in the real world, especially in places very different from where the model might have been conceived.
That's a great point. And for you listening, whether you're dealing with complex reports at work or you're just curious about how these huge global decisions get made.
Or should get made.
Right. This whole story shows why it's so important to look under the hood of those neat, objective-looking metrics. There's always a story behind the numbers, always assumptions, and often a real debate about whether they're truly valid or fair. Exploring this 1993 report and its critique really leaves me wondering, how do we move forward? How can we design global health approaches that are data-informed, efficient enough for making tough choices,
but also flexible, ethical, and sensitive enough to respect human diversity and local priorities all around the world?
Exactly. The huge question. Definitely something to think about.
Indeed.
Thank you for joining us on this deep dive today. Keep questioning, keep exploring.
And we'll catch you next time.